We have learned in previous session about the natural history and the serological marker of hepatitis C virus. How to investigate we have already learned. Now, it is the time when we should learn how to treat our patient. In this session of treatment, we have divided into 3 sections, and in which we will learn about the hepatitis C virus treatment. First section will deal about the low risk patient, the treatment. Second section will give some hands on exercise with the case based learning, and third section will deal with the treatment of HCV infection in a specialized population, such as those with HIV co-infection or with HBV co-infection. So, I will start with the first section. In this lecture, we will learn how to investigate, how to evaluate clinically, and what laboratory test to perform if a patient is found to have anti-HCV positive, how to make sense of them, and what are the drugs which are available to us for HCV treatment, what are the treatment regimes which are available to us, and how to choose the most appropriate treatment regimen for a given patient. All these presentations are based on the most recent guideline for HCV treatment released by WHO in July 2018. Just to emphasize the importance of anti-HCV antibody test, I will take an analogy with the measles. Whenever there is a viral infection or bacterial infection such as measles, host immune system develops antibody against the pathogen, and this antibody continue to circulate in the body for life, and it prevents the second episode of infection. It gives us lifelong immunity. Same thing happens when a person is exposed to hepatitis C virus infection. After some time, anti-HCV antibody is formed, which we are testing with routine screening test. Even after successful treatment, this antibody continue to circulate in the body, and hence a patient remains anti-HCV positive after successful treatment. This we need to emphasize to our patient, otherwise it will cause unnecessary anxiety in patients. When a person is found to be anti-HCV positive, we have to answer certain questions with the help of history, examination, and appropriate investigations. The first question is whether we are dealing with an acute infection or chronic infection, whether the chronic infection is active or it has resolved on its own, whether the chronic infection has progressed to cirrhosis or not. If there is cirrhosis, then it is decompensated or compensated cirrhosis, and what are the other conditions or comorbidities which we must consider, which can influence the treatment decision, duration, or the outcome. So, first let us differentiate between acute and chronic infection. If infection continues for more than 6 months, means if HCV RNA continue to persist for more than 6 months, it is chronic infection, and all those with chronic infection need treatment. A small proportion, 1/4 of those with acute infection resolves on its own. So, treatment for acute HCV can be delayed to gain the benefit of natural clearance, but based on most of the laboratory tests, we cannot differentiate whether we are dealing with acute infection or chronic infection. We can suspect that a person is suffering with acute infection if we have certain risk factor which predisposes for HCV transmission to a susceptible host. Suppose we have a history of recent blood transfusion or history of an unsafe sex with a person who was HCV positive, a patient who is on hemodialysis. So, these are the certain conditions which predisposes for HCV transmission, and we can consider a patient is likely to have HCV infection, especially if he was known to have anti-HCV test negative or HCV RNA test which was negative and is now changed to their positive status with or without associated liver enzyme elevation. But in real life practice, it is very difficult to identify any acute HCV infection, and all those with HCV positivity should by default can be considered as chronic HCV infection. Now, in chronic HCV infection, we have to establish whether the person is still harboring virus or only antibody is circulating and the virus has been cleared by the body, means the infection is resolved. This can be clarified with the test of HCV RNA. Those with active infection will have HCV RNA positive status. In countries or places where core antigen test is available, core antigen positivity will also indicate the existence of active infection, and all those with active infection shall be treated. WHO guideline has 3 sections. One is screening for possible HCV infection, second confirmation of active infection, and third section deals with the treatment of HCV infection. We have already learned how to screen the population with the help of anti-HCV antibody. If one test is positive, we should go ahead with the further testing for the confirmation, and the confirmation can be done either with the HCV RNA or core antigen, whichever is available. And if RNA or core antigen is positive, that means the person is having active infection and treatment is indicated. So, all those with active infection as suggested by detectable HCV RNA or core antigen shall be considered for treatment. Why not to treat for those less than 12 years of age? Because none of the drugs are approved for use in children less than 12 years of age. But do not worry, we can counsel the parents of the children who are HCV positive that the child need only monitoring, and treatment can be started as and when the drugs are approved or after the age of 12 years, whichever occurs first. I will like to remind here, which will help us to the counseling of the parent, that hepatitis C virus does not progress to cirrhosis very fast. Roughly it takes 20 years to progress to cirrhosis after infection. So, even if infection is acquired at birth, we can start treatment after 12 years and child would have not progressed to cirrhosis. And a small fraction means 20% develop cirrhosis. Most of the patients who are infected with HCV infection do not progress to cirrhosis. So, coming to the treatment part, treatment has 2 essential portions. First, we have to assess every patient for the presence or absence of cirrhosis, and if cirrhosis, then it is compensated or decompensated, and other associated condition which will guide us through the treatment. How to assess for the fibrosis? We have learned in previous section that fibrosis is assessed with the gold standard of liver biopsy, which has several limitations. So, we prefer to use non-invasive markers. There are several non-invasive markers from clinical parameter, indirect test, hemogram, liver function test, ultrasound, non-invasive tests such as transient elastography or fibroscan, and the most easily available and accessible is APRI index, means APRI index, AST platelet ratio index, which we have learned how to calculate. The calculation of APRI index just need AST measurement and platelet count. I will again like to remind here that AST ALT measurement should be done in a fasting state after overnight fasting in a resting stage, and sample should be processed as soon as possible after serum separation. APRI more than 2 suggest that the person is suffering with cirrhosis, and the presence of features of decompensation will help you to guide whether the cirrhosis has decompensated or not. And these are the features of decompensation: presence of any one of them, ascites, encephalopathy, bleed, or jaundice along with prothrombin time prolongation will qualify for decompensation. We also need to assess the liver dysfunction in every patient, which will help us to see the improvement in liver function test in due course of time after successful treatment. The most commonly used measurement is child book score, which can be done in day-to-day practice. It needs measurement of 5 parameters: presence or absence of encephalopathy, ascites, bilirubin, albumin and prothrombin time prolongation, and each of them are marked according to the laboratory parameter and the clinical variables, and score is generated. CTP score up to 5 or 6 is called as CTP class A. Score between 7 to 9 will be called as CTP class B, and 10 to 15 will be qualify for CTP class C. How the treatment of hepatitis C virus has evolved? The first treatment appeared in 1990, yes, almost 30 years ago. The treatment was started with plain interferon, which was given by subcutaneous route thrice in a week. But this treatment was very ineffective. Only 7 to 10% of the infected patients were able to clear their virus. Very soon it was identified that if we can add ribavirin to the interferon, the treatment response will increase from 10% to 25%. And even in present era, ribavirin is used in selected cases, though the importance of ribavirin has reduced in present era of oral drugs, which is DAA. After plain interferon, pegylated interferon was identified, and it was found that the treatment response is further increased from 25% to 45% or 50%. Another advantage of pegylated interferon was that it need administration only once in a week. But interferon and pegylated interferon both had several advantages. Most important, they causes high grade fever, myalgia, loss of appetite, loss of hair and pancytopenia. So, patient need regular monitoring, supportive medication and lots of counseling so that they can successfully complete treatment. In last 2 decades, we can see there is drastic change in SCV treatment when oral drugs are introduced in the market. These drugs are called DAA, direct acting antiviral drugs. These drugs have several advantages. They give more than 90% success rate. They are free of side effect and are also available at a cost which is much lower than the pegylated interferon. Various drugs act in different protein. Hepatitis C virus is an RNA virus. Its genome produces 10 types of proteins, and different oral drugs acts on different protein. We need not to remember them. All the oral drugs for hepatitis C virus are acting on the major protein NS3 protein, NS5A protein or NS5B protein. These are the different drugs which are either marketed or in different phase of clinical trial, and their site of action we need not to remember them because we are not going to use all of them in our treatment protocols. So, as we have learned, only 3 class of drugs we are using, and it is easy to remember their name also. NS3 protease inhibitor, the name of the drug ends with previr, they have suffix of previr. The example is simepravir. Second group of drug is NS5B inhibitor. Their drugs have a suffix of buvir, like sofosbuvir. Third group is NS5A inhibitor. The drug name ends with asvir, like daclatasvir. So, if we can keep these suffix in our mind, we can identify that a given drug belongs to which group of drug. It is also easy to remember this suffix. NS5A, if we can keep this A and the suffix start with A. NS5B, suffix start with B. NS3, protease inhibitor P and suffix start with P. So, it is very easy to remember and we need not to spend lots of time that to identify which drug belongs to which category. Now, coming to the treatment. Earlier we were using interferon based treatment with pegylated interferon and ribavirin, which as we have discussed had lots of adverse effect, very costly and much less effective. So, now only interferon free oral drug based treatment are recommended. These drugs are called DAA. All the recommended regimen uses NS5B inhibitor sofosbuvir as the backbone, which is used in addition with either NS5B inhibitor, NS3 inhibitor or NS5A inhibitor or both of them. So, in all patient NS5B inhibitor is always used in combination with one of these drug or both. These are the list of the drug which WHO recommend for treatment of hepatitis C virus infection in different patients. We will learn more about it. Before I move ahead, I will like to emphasize here that sofosbuvir and ledipasvir are not marketed separately. They are available in a single dose drug combination in single tablet. Similarly, sofosbuvir and velpatasvir is also marketed in combination in a single tablet form, and sofosbuvir declatasvir was initially marketed as separate drugs, but in few places it is also marketed as a combination drug, but most of the places and most of the country it is marketed as separate drugs. Ribavirin, it is available in a strength of 200 milligram capsule. It is used in selected cases, which we will learn in due course of time. We have investigated our patient and identified that the person is having active SCV infection. Now, we have to choose which drug combination is most appropriate for our patient. We need these data. First, age of the patient. Second, HCV genotype. Please mind, HCV genotype is not needed in all the patient. Where we need to do HCV genotyping, we will learn in a minute. But in few patients, we will need HCV genotyping. For majority of the patients, we don't need HCV genotyping if we are using a pan-genotypic drug, depending upon the availability in the country. We also need to know whether the patient is having cirrhosis or not. Why? Treatment may not differ in presence or absence of cirrhosis, but all those with cirrhosis will definitely need follow-up for the complication of cirrhosis after successful hepatitis C virus treatment, such as hepatocellular carcinoma, esophageal varix, ascites and other complication. So, what drug is effective against which genotype? In this slide we will learn. Genotype 1, 4, 5 and 6, they are more or less similar and treatment is same for them. For genotype 2, it is easy to treat and can be treated with sofosbuvir and ribavirin combination only. Genotype 3 is considered to be difficult to treat, but now the data is emerging and suggesting that it is as good in response as other genotypes. How a patient with cirrhosis differ with those who are not having cirrhosis? I will like to emphasize here that those with cirrhosis will need longer duration of treatment, means a non-cirrhotic patient can be treated with 12 weeks of therapy, but a cirrhotic patient may need 24 weeks of treatment. A cirrhotic patient may also need addition of ribavirin. Addition of ribavirin has 3 benefits. It improves the response rate. It can shorten the treatment duration from 24 weeks to 12 weeks, and also it reduces the relapse rate, because cirrhotics are at higher risk to relapse after successful HCV treatment. But keep in mind, use of ribavirin, which is a toxic drug, will ask for more intense monitoring during the treatment. All those with cirrhosis will need monitoring and follow-up even if virus is cleared and patient is cured of virus. So, what are the treatment regimens? This is what recommended by WHO, which we have simplified here. At the time of pre-treatment assessment, we have identified whether cirrhosis is present. If present, it is compensated or decompensated. We have a data on baseline laboratory investigation, assess the complications of fibrosis or cirrhosis with the help of endoscopy. HCV RNA, it is detectable, and genotype, yes, genotype is needed only if the age of the patient is 12 to 17 years. That is why I told that we do not need HCV genotyping in all the patients. If a person who is found to be HCV positive and RNA is detectable, we need to treat them. Here we have to see the age of the patient. If age is 12 to 17 years, we have to use genotype specific treatment. And to use genotype specific treatment, we need to know what is the genotype of the virus which is circulating in our child. If the age is more than 18 years, we can use pan-genotypic treatment regimen. So, when we are treating an adult, means we are going to use a pan-genotypic regimen. So, what are the pan-genotypic regimen? These are the one. In those who are not having cirrhosis, we can use sofosbuvir, valprotasvir, sofosbuvir, daclatasvir, and glicapavir, piperentasvir for different durations, which are summarized here. Please note, WHO has given multiple options so that we can meet the availability of the drugs in different countries, because in different countries may have different drugs which are available to them, and they can have different option which is the most affordable and easily available to them. Similarly, in those with cirrhosis, we can use sofosbuvir and valprotasvir for 12 weeks, soft dacla for 24 weeks, glicapavir and piperentasvir for 12 weeks, and soft dacla for 12 weeks. I will like to highlight the 2 points here. First, in presence or absence of cirrhosis, both sofosbuvir and valprotasvir, which is a pan-genotypic drug, is to be given for 12 weeks only. In decompensated cirrhosis, the treatment can be prolonged for 24 weeks. So, presence or absence of cirrhosis will not affect the treatment duration for valprotasvir. It will make the treatment protocol easy. So, in the countries where facilities for fibrosis assessment is not available, or we want to make treatment more homogeneous so that the implementation is easy, we can opt for sofosbuvir and valprotasvir combination for 12 weeks. Otherwise, we can go for sofosbuvir and daclatasvir, but the treatment duration will be longer to 24 weeks. Soft valpa combination is costlier than soft dacla combination in most of the country. Please note that in countries where genotype 3 prevalence is less, we can use soft dacla for 12 weeks only, and it will not affect the outcome. In a child, we have to do genotype. If genotype is 2, we can give soft riba for 12 weeks. If genotype is 3, we can use soft riba for 24 weeks. If genotype is 1, 4, 5 or 6, sofosbuvir and ladipasvir combination can be used for 12 weeks. We can now use daclatasvir or ladipasvir because these drugs are not approved for children age 12 to 17 years. Ladipasvir is the only drug which is approved for use in this age group. So, and ladipasvir is effective against genotype 1, 4, 5 and 6. So, those with genotype 1, 4, 5 or 6 can be treated with SOF and LADI combination. How to measure the effect or the response with the treatment? We have started the treatment for 12 week, 8 week or 24 week, whichever protocol we have chosen. After that, we have to stop the antiviral drug, wait for 12 week and retest the patient for hepatitis C virus RNA. This is called as SVR12, means sustained virological response at 12 week. If virus is not detectable at 12 week after stopping treatment, we can say that the patient has achieved SVR12, means virological response is sustained after 12 week of stopping treatment. Most of the oral drugs are highly effective. In absence of cirrhosis, 95 to 98% of the patient achieve SVR12, and in presence of cirrhosis the response is slightly lower. Still 80 to 90% of the patient successfully clear the virus and achieve SVR12. I will like to emphasize here that after we have achieved SVR12, means virus is not detectable after 12 weeks after stopping the drug. We need not to retest the person for RNA repeatedly every 3 months or 6 months or even in life. Only those patients who are at constant risk of acquiring HCV reinfection, we need to monitor them with RNA as per the guideline laid for the specific group. These high risk population are like patients on maintenance dialysis, patients with thalassemia because they need repeated blood transfusion, or hemophilia. When we are using this drug, we should also be thinking about some drug to drug interaction, because some significant drug interactions are there, like sofosbuvir interact with amiodarone. So, if due to some cardiac illness patient is on amiodarone, we should try to avoid amiodarone. It is not approved for use in those with GFR less than 30 ml per minute, means patient with stage on hemodialysis, this drug is not approved. Daclitazivir, it induces it interacts with the drugs which inhibit the cytochrome P3A activity, and ribavirin should not be used in a pregnant women or those who are in cardiac failure, because it causes hemolysis and hemoglobin can fall suddenly, and in patient with cardiac disease or COPD, a fall in hemoglobin can cause problem. How to monitor a patient? If we are not using ribavirin, there is not much of monitoring needed because of drug treatment. We need to evaluate the person at the baseline and at 12 weeks after stopping treatment. But if we are using ribavirin, then we need to monitor for hemoglobin drop and supportive treatment such as iron therapy, erythropoietin, or occasionally blood transfusion during the treatment, so that the person can successfully complete hepatitis C virus treatment. During treatment, we have to monitor for the adherence to the drug, because it is a long 3-month treatment or sometimes 6-month treatment. We have to counsel the patient for remain adherent to the drug therapy, for the possible toxicity, any drug to drug interaction, and after stopping treatment we have to continue to follow all those with cirrhosis for the complication of cirrhosis, such as hepatocellular carcinoma, varicose bleed, appearance of ascites, development of hepatic encephalopathy, and other complication. So, in summary, all those with detectable HCV RNA and age more than 12 years shall be considered for treatment. At present, treatment is done with orally active drugs which are highly effective. They cure more than 90% of those with HCV infection. Treatment is monitored with HCV RNA at 12 weeks after stopping the treatment, which is called as SVR12. Once SVR12 is achieved, we need not to repeatedly do scvRNA testing. Patient with decompensated cirrhosis need longer duration of therapy and they have at risk to relapse after successful treatment. Patients with cirrhosis should also be monitored after successful treatment for the complication of cirrhosis and portal hypertension. Those with on ribavirin should be closely monitored for the complication of ribavirin use, especially drop in hemoglobin, and they may need supportive treatment. I hope that with this session you would have gained adequate skill to decide about your patient, that how to investigate and which treatment regimen is most suitable for a given patient. In next session, we are going to apply this skill with a case-based learning. See you then. Thank you.